Hello everyone and welcome to the third lecture in the topic of bradyarrhythmia, and as we know it's titled AV blocks. In our lecture today we are going to learn the types of AV block and how to diagnose each one of them, and we are going to learn the types of escape rhythm which associate AV blocks and sometimes of course sinus node dysfunction as we learned before, and how to diagnose each one of them. And as we already know, we are not talking here about the indications of pacing in this lecture, as we are concerned with the ECG diagnosis, not with the management. Of course, AV blocks is the second most important type of bradyarrhythmia, as the same as sinus node dysfunction, and they are very common to see in our clinical practice. And we have various types or degrees of AV blocks that we are going to learn today. Of course, don't forget to exclude secondary causes in case that you diagnose AV block. The most important thing to exclude is drug-induced effects, and of course to exclude inferior STEMI, to exclude hypothyroidism, severe hyperkalemia, post-operative, post-ablation, and Lyme disease, as we learned before in the lecture of classification of bradyarrhythmia. And if these causes are excluded at the time, we can think of degenerative pathology, which is a very common cause of AV block. And diagnosis of AV blocks is very important because according to our diagnosis and our decision on the degree of AV block, whether it is a benign type of AV block or it is high-grade AV block, we can decide whether this patient would need temporary pacemaker or not, and after this a decision for permanent pacemaker or not according to presence of reversible cause or absence of reversible cause. We are going to start with the first degree AV block. In the first degree AV block, there is fixed conduction delay in the AV node or the His bundle. So we can see that the PR interval is longer than normal because of this fixed delay, and it is static, so it is not progressively longer. So in first degree AV block, I find fixed conduction delay in the AV node, and it is reflected on the ECG as prolonged PR interval. So for example, here in this ECG, we can find that the PR interval is longer than 200 milliseconds. As we remember from the ECG interpretation lecture, the normal PR interval is from 120 milliseconds to 200 milliseconds, so it is one large square. So when the PR interval is longer than one large square and it is static, not dynamic, so I can call this first degree AV block, and it is caused by prolonged conduction delay in the AV node or His bundle. So for example, here in this ECG, we can see in the strip here that the PR interval is longer than one large square and it is static, not dynamic, so it is first degree AV block. Let's move to the second degree AV block, which has two subtypes, Mobitz type 1 and Mobitz type 2. Mobitz type 1, of course, show a very famous phenomenon that is very well known to us, which is the Winkie-Pack phenomenon. In the Winkie-Pack phenomenon, there is progressive conduction delay in the AV node due to the decremental properties of the AV node, which is exaggerated here. So I would give an example here. The first wave or the first cycle shows that there is a conduction from the atrium to the ventricle normally without any problem. In the next cycle, the conduction is slower, and so the PR interval gets longer. And for example, here the third beat was blocked in the AV nodes, and so the P wave was not followed by a complex. And then in the next cycle, this is going to start again by shortening of the PR interval in order to start a new cycle or a new cluster. And so after the blocked P wave, then the atrial conduction to the ventricle is restored, or the AV nodal conduction is restored with a shorter PR interval. So let's see it practically on an ECG. For example, in this strip, we can see here that there is a P wave conducted to the ventricles as a complex, and so there is no problem here. The PR interval seems normal. Then in the next cycle, there is longer PR interval due to slower conduction in the AV nodes, so it is progressive conduction delay. Then in the third cycle, there is much longer PR interval, and then in the fourth cycle, the P wave is plugged as AV node, and so there is no complex here. And then followed by this, after this progressive prolongation of the PR interval due to the progressive conduction delay, the PR interval gets shorter again, and then a new cycle is started with progressive prolongation of the PR interval till it is blocked again. So the PR interval decreases again, follows the blocked P wave, leading to the formation of what's called clusters in the Winkie-Pack phenomena. So the Winkie-Pack phenomena is characterized by progressive conduction delay in the AV node, reflected as progressive prolongation of the PR interval till a P wave is plugged, and there is no complex, and then a new cycle is started with shortening again of the PR interval followed the blocked P wave. So this is called clustering of beats, which is evident in Winky Pack phenomena. And of course the blocked beats can occur with the second cycle, with the third cycle, the fourth cycle, the fifth cycle, etc. It is not, for example, a fixed number or like a certain order that the blocked beat should occur in the third beat or in the fourth beat. It may even occur in the second beat or even in the fifth beat. So the etiology here is that each successive atrial impulse has a longer and longer delay in the AV node until one of them fails to conduct through the AV node. So for example here we can see in this ECG that we can see progressive prolongation of the PR interval till we find that there is a 1 P wave without a following complex, and then it gets shorter again. We can see this example in these two strips: progressive prolongation of the PR interval till 1 P wave is not followed by a complex, and then it gets shorter again. And so we have clusters of beat here in this example. Now we are dealing with benign types of AV block, because first degree AV block and second degree Mobitz type 1 are considered benign type of AV block. The problem is that we are moving now to the high grade AV block, which may need specific management in the ER. Second degree AV block Mobitz type 2, and here we have a fixed conduction defect in the His bundle or below. Usually it is in the His, not in the AV node, and causing fixed pattern of block. So it is not just delay, no, there is block of a certain order in the His bundle or below, like 2 to 1 or 3 to 1. So let's explain much more. For example, one beat can pass through the ventricles without a problem. It may pass normally or may pass slower. But for example, the second beat is not conducted, and so after I have a P and a complex, I can have, for example, a P without a complex following it. So it is different from first degree AV block, which was just a fixed delay in the AV node, but each P wave is followed by a complex. And it is different from Mobitz type 1, which shows progressive conduction delay in the AV node till one beat is not conducted. Here I have a fixed order of blockade, like 2 to 1, each 2 P waves, one of them is conducted and one is blocked, or 3 to 1, each 3 P waves only, for example, 1 is conducted and 2 are not conducted. So 3 to 1 is a higher grade than 2 to 1 and much worse prognosis than 2 to 1, for example. So here, for example, in this ECG, we can find here that we have a P and a complex, but then you have 2 P waves without a complex, and then we have a P with a following complex, and then 2 P waves without a complex, and then this repeated again. So for example, here we can have 3 to 1 AV block. So occasional P waves are completely blockaded with a fixed ratio. This is called second degree Mobitz type 2. And this etiology is that conduction is all or nothing. There is no prolongation of the PR interval, and there is no clustering of beat, as we mentioned, but it is a fixed ratio of blockade, and so we consider this type a higher grade of AV block than first degree or Mobitz type 1. And usually the blockade here occurs in the His bundle or below it, not in the AV node, because usually the AV node shows the decremental properties which was reflected in Mobitz type 1, but Mobitz type 2 is usually a behavior of His bundle or an infrahisian blockade. Now we can see this example here from a real ECG. We can see here that we have between each 2 complex we have 2 P waves. One of them is not conducted and one of them is conducted as followed by a complex. So we can have here 2 to 1 AV block. And so we can see here like each T wave has like a superimposed P wave on its descending slope or descending limb. So we have here an example of 2 to 1 AV block. Most probably it is Mobitz type 2 due to the wide complex, as we are going to explain later the issue of the 2 to 1 AV block. And now to the worst type of AV block, which is the third degree AV block, or like many cardiologists prefer to call it, complete heart block, because it is a complete blockade. Here there is no conduction at all between the atrium and the ventricle, and so the P waves working independently from the complexes, as the atrial activity is paced by the SA node and the ventricular activity is paced by an escape rhythm like junctional or idioventricular rhythm, which is of course a slower rhythm than normal. So usually I would see a ventricular rate that is slower than the atrial rate and is completely independent, and this is what we call complete AV dissociation, because here, as we see, that there is no affixed one-to-one relationship between the P wave and complex. We don't have here that each P wave is followed by a complex, or sometimes they are followed by a complex and sometimes they are not followed like in the other types. No, the ventricular activity is completely dissociated from the atrial activity. So this is what we call complete AV dissociation caused by third-degree AV block or complete heart block. So for example here the P waves are completely blocked in the AV junction, and so QRS complex originate independently from below the junction. So for example here we can find some P waves preceding the complex, some P wave coming after the T wave, some P waves coming superimposed on the complex or superimposed on the T wave. So this is AV dissociation. And of course, as we know, the etiology here is like the complete block of conduction in the AV node or the His bundle. So the atria and the ventricles are independent from each other, and the ventricle is based by escape rhythm. So we have two patterns of complete heart block, which are like anatomical types according to the level of the blockade. We have supraHessian and infraHessian. From its name, we can expect what's meant by each one of them. SupraHessian AV block escape rhythm arise from just below the AV node and pass anterogradially through the His Purkinje system, because the level of block is mostly above the His bundle, mostly in the AV node. And because the escape rhythm here pass through the His Purkinje system, so it is passed through the normal conductive pathway of the heart, so it shows narrow complex and slow rhythm, so it is called escape junction rhythm. Whereas in infraHessian, the level of block is usually below the His bundle, maybe for example at the ends or in the bundle branches, and so escape rhythm arise from below the His bundle and pass anterogradially through the ventricular muscle fibers rather than the His Purkinje system, and so it would lead to a wide complex rhythm, may show left bundle or right bundle branch block morphology with slow rhythm, and of course it is called escape idioventricular rhythm. And which is more worse, supraHessian or infraHessian? Of course, infraHessian block is much more worse than supraHessian, because escape idioventricular rhythm is considered as an unstable rhythm that may degenerate easily into asystole, and so infraHessian block of course is much worse than supraHessian block. So once you diagnose complete heart block and you find that the escape rhythm is wide complex, it is considered escape idioventricular rhythm and you should rush for a temporary pacemaker. So as we know, remember that when the impulse originates in the ventricle, the conduction through the ventricular muscle fibers will be inefficient and the QRS will be wide with left bundle or right bundle morphology, whereas the escape junction rhythm is completely different, of course. So in the top image, it is like escape idioventricular rhythm, and in the lower image, it is different from this. So of course we have a very famous question that we usually ask ourselves when we see a patient with 2-to-1 AV block. When we were juniors residents, of course, we asked this to the senior resident: is 2-to-1 considered a Mobitz type 2 because it is a fixed block? Yes, 2-to-1 seems reasonable that it is Mobitz type 2. Each two P waves, one of them is conducted and one is not conducted, so it should be considered type 2. But the answer is that it can be Mobitz type 1 and it can be Mobitz type 2. So how come? It may be Mobitz type 2, of course, because of the fixed pattern of blocks that we learned before. But it may be Mobitz type 1. And the second beat is the blocked beat as in Winkie-Pack phenomena. As I told you, in the Winkie-Pack phenomena, the blocked P wave usually is the third or the fourth, but it may be the second. So 2-to-1 may be just a benign presentation of Mobitz type 1, and so it is a benign arrhythmia, or it may be like Mobitz type 2 and it is a fixed pattern of block, and in this case it is considered high-grade AV block. So 2-to-1 may be Mobitz type 1 or Mobitz type 2, and usually we deal with this as being type 2 in order to expect the worst scenario. But how can we differentiate? There are two methods to differentiate. The first one is just simple. In the ECG, if I find that the complex are narrow complex, so it is mostly escape junction rhythm, I expect that it is most properly type 1, Mobitz type 1, of course, because in Mobitz type 1 the level of blockade is usually in the AV node, and so I usually find that there is escape junction rhythm. Whereas if it is wide complex, as we saw in the examples before, mostly it is type 2. So 2-to-1 AV block with narrow complex, mostly it is type 1. 2-to-1 AV block with wide complex, mostly it is type 2. Is there another differentiation between them? Yes. And this is a chance, of course, to understand what is the effect of atropine on each one of AV block. In the first degree AV block, if you give IV atropine, you can find an increase in heart rate and slight shortening of that PR interval, and it is something expected and makes sense. In third degree AV block, which is the highest degree of AV block, there is no effect of atropine on the heart rate at all. The ventricular rate would be the same. There may be some increase in the atrial rate due to acceleration of the SA node, but the ventricular escape rate would be the same. So complete heart block would not be affected by atropine. If it is second degree Mobitz type 1, I may find some increase in the heart rate. As we mentioned that Mobitz type 1, the monkey pack phenomena, is a benign type, and this AV blockade or the progressive conduction delay in the AV nodes may be improved by the atropine. But in Mobitz type 2, we find a strange result, which is paradoxical slowing of the heart rate. So I think this one is the most weird answer. Why does atropine cause paradoxical slowing of the heart rate, although atropine is an anticholinergic medication that should increase the heart rate because it is a parasympathetic medication? And the answer is simple. We know that the AV node shows something called decremental behavior, in which if it says that the atrial rate is increased, it increases the level block, so not all the impulse pass to the ventricle in order to protect the ventricle. This is called the decremental behavior of the AV node. So for example, if the patient has 2:1 AV block caused by Mobitz type 2, the atrial rate, for example, was 80 beats per minute, and so the ventricular rate was the half, which was 30 beats per minute, and then you give IV atropine, assuming that you are increasing the heart rate and you are helping the patient, what would happen? The atrial rate was increased, for example, to 90 beats per minute. And what would be the behavior of the AV node? That because of the decremental behavior, it would increase its rate of block from 2:1 to 3:1, a higher grade of block. And so the ventricular rate would get slower. It would be the third. It would be 30 beats per minute. And this is what we call paradoxical slowing of the heart rate. So can I give IV atropine to a patient with second or third degree AV block? If the ECG show 2:1 AV block with twin complex, mostly it is infrahisian, and mostly, of course, it is Mobitz type 2. So please don't use atropine because it may worsen the patient. And atropine, of course, is futile in patient with third degree AV block, and so it would not help. But in second degree Mobitz type 2, it would worsen the patient. So beware of atropine and when to use it. For example, in this ECG, we can see here, and if we look at the strip, we have like complete AV dissociation, as we say. Here we have complete AV dissociation, as we saw here, because some P waves come before the complex, some P waves come superimposed on the complex, some of them come superimposed on the T wave. There are complete AV dissociation. Here, for example, we have the same. We have also complete AV dissociation because we don't have, for example, a fixed PR interval in order to mention that it is like 2:1 or 3:1 or 4:1 even. Sometimes the P is very near to the complex, sometimes it is far from the complex, and so it is not second degree Mobitz type 2, it is also third degree due to complete AV dissociation. And for example, here we can find that there is complete AV dissociation as well. But it is not the only finding. We have also another finding here, which is very, very important to recognize in patients with AV block, especially in Mobitz type 2 and third degree. We have ST elevation in inferior leads and reciprocal depression in 1 AVL. And so it is not just third degree AV block, it is third degree AV block complicating inferior STEMI. So please, in any patient with complete heart block, it is important to check the inferior leads for ST elevation in any patient with any degree of AV block, because it is a very famous reversible cause, and this patient doesn't just need transient pacemaker, no, he would need primary PCI. And if you revascularize the right coronary artery in most of the cases, or LCX in fewer of cases, this heart block would be reversible. And this is what we mentioned at the start of our lecture. Please check for reversible cause, and it is a very important cause to check is the inferior STEMI. Now we should also remember that presence of complete heart block doesn't mean that retrograde AV conduction should disappear. This means that there may be blockade in the AV node, but it is just for the anterograde conduction, but retrograde conduction can still occur from, for example, a PVC or pacemaker mediated tachycardia. So presence of complete heart block doesn't prevent retrograde atrial conduction of PVC and doesn't prevent pacemaker mediated tachycardia in patients with dual chamber pacemaker. Of course, this would be explained later in separate lecture, but this is an important notion that we should remember. Now we are moving to the escape rhythm. And escape rhythm, of course, we remember from the classification of bradyarrhythmia lecture that there are many foci in the heart that can produce abnormal automaticity, and so they can pace the heart in case of presence of any abnormality in the SA nodes. Of course, SA node is a normal pacemaker of the heart, which usually pace at a rate between 60 and 100, but an atrial escape rhythm can occur at a rate of less than 60 beats per minute, An escape junctional rhythm can occur as an AV node at a rate of 46 beats per minute, at a ventricular escape rhythm, which is called usually escape idioventricular rhythm, can occur at a heart rate usually slower from 20 to 40 beats per minute. And so the highest frequency decide which would be the normal pacemaker, which is usually the SA node. So in case of sinus node dysfunction or AV blockade, a junctional rhythm can occur which is characterized by narrow-complex, regular rhythm and absent P wave, or sometimes they may be inverted shortly before or shortly after due to retrograde conduction to the atria, but usually we don't see them. And usually the heart rate in junctional rhythm, if it is 60 to 100 beats per minute, it would be accelerated junctional rhythm. If it is less than 60 beats per minute, it would be called escape junctional rhythm, which we are dealing with here. And if the heart rate is more than 100, it is usually called junctional tachycardia. And what we are dealing with here is escape junctional rhythm, because we are speaking about the bradyarrhythmia. So for example here we can see that there is regular narrow-complex rhythm with absence of P wave, and usually the heart rate is slower here, and so we can call this escape junctional rhythm. And also, as we remember the criteria here, we mentioned that heart rate is less than 6 beats per minute, absent P waves or sometimes retrograde P wave before or after, and narrow-complex, and it is characterized by a very important criterion, which it is a very more stable rhythm with less risk of pauses or asystole. So for example here it is another example of escape junctional rhythm in which we can see that the P wave may appear slightly after the complex, but we can consider this that there is escape junctional rhythm and I can't see clear P wave, and it is regular and narrow-complex, so it is escape junctional rhythm. Then we can move to the idioventricular rhythm, which is of course a rhythm arising from the ventricle, like for example from the bundle branch or from the ventricle itself, and it is characterized by wide complex, regular rhythm, absence of P wave, or sometimes they may be dissociated from the complex if it is still, the SA node is still working, but the problem in the AV node. Heart rate, if it is from 50 to 100, and here we usually get a lower number, not 60, from 50 to 100, it is called accelerated idioventricular rhythm, which is called IVER, which is a very famous term for it. If the heart rate is less than 50 beats per minute, it is escape idioventricular rhythm, and heart rate if more than 100, it is ventricular tachycardia. And here we are dealing of course with escape idioventricular rhythm. So what does the prefix idio mean here? Idio means that it is its own distinct or peculiar rhythm to the shaper. So idioventricular rhythm meaning that it is a distinct rhythm arising from the ventricular muscle fibers themselves. And so escape idioventricular rhythm is characterized, as we mentioned, by absence of P waves, and there are no fibrillator waves usually, regular and slow rate, and with wide complex. And so it is escape. And so we can summarize the criteria again of escape idioventricular rhythm, which show a heart rate less than 50, usually it is between 20 and 40 beats per minute, absence of P waves, and there is wide complex left bundle or right bundle branch block morphology, and usually it is an unstable rhythm with liability to develop pauses or even asystole. So it is a very dangerous rhythm to see. We can see another example here where there is wide regular escape rhythm with slow heart rate and no P waves, so it is escape idioventricular rhythm, which is a very dangerous type of rhythm. And always we should remember that the disease process resulting in the appearance of escape rhythm is more important than escape rhythm itself. So it is not just a diagnosis to mention that the patient has escape junctional rhythm or escape idioventricular rhythm, but you should comment whether it is caused by sinus node dysfunction, in which I would not see sinus P wave, or it is caused by complete AV blockade, for example, in which I would see sinus P wave, but they are dissociated from that complex. So escape rhythm is not a disease itself, it is a manifestation of another disease, which is either sinus node dysfunction or complete AV block. Sometimes we may find some patients who are having one-to-one AV conduction, and all of a sudden there is disappearance of the intrinsic ventricular conduction. Like for example here we could see that there is one-to-one relationship, and all of a sudden there is no ventricular beat and there is no even escape rhythm. This is very common in old age, of course, and this may lead to episodes of like loss of consciousness or complete syncope. Sometimes they are called Adams-Stokes attacks, which is a classic term, in which there is no escape rhythm. So usually escape rhythm appears in middle age, but in very old age the patient may have complete loss of conduction, and there may be third degree AV block without any escape rhythm, as we can see here from this Holter tracing. And now we can have another question to ourselves in order to cover the topic of AV block. Can third degree AV block occur with atrial fibrillation? Of course, yes. We can have third degree AV block on top of AF. For example, here we can see here that the patient has fibrillatory waves as you have irregular chaotic pattern, but it is regular and slow as the heart rate may be like 60 beats per minute here. So this is AF with third degree AV block. And the question is why? Why did we call this AF with third degree AV block? Of course, we know that AF is caused by multiple wavelet re-entries inside the atria, and usually it is conducted through the AV nodes, which may be controlling the conduction, leading to AF with controlled ventricular rate, or it may be conducting the atrial beats rapidly to the ventricle, leading to AF with rapid ventricular rate. So when we have complete AV block, an escape junctional rhythm or escape idioventricular rhythm paces the ventricle, and so it is escape rhythm, so the ventricular rhythm would be regular by the escape rhythm because the atrial chaotic rate is not transmitted to it. So any patient with AF who gets regular ventricular rate, I would expect that this patient developed complete AV block. So this is a very important thing to consider in ECG diagnosis. Whereas here we can see that this is a patient who have atrial fibrillation because of fibrillatory waves, but the heart rate is slowed but still irregular. So we can call this AF with slow ventricular rate. Why did you call this AF with slow ventricular rate and you didn't call this AF with complete heart block as the heart rate is slow? Here there is still intrinsic AV conduction, but it is slowed down. So for example here, when this patient has slowed conduction, the same chaotic atrial fibrillating rhythm is still conducted to the ventricle with the same irregularity, but at a slower rate due to a disease in the AV node. Maybe it is like degenerative disease, or maybe it is medication effects, because the patient has taken too much negative chronotropic medication. And so the ventricular rate would be slow, but it is still irregular, because the intrinsic ventricular conduction comes from the chaotic atrial rhythm, not from escape rhythm. And so this patient has AF with slow ventricular rate because here the AV node is still conducting, and so there is no any need for escape rhythm to operate in this case. So remember, once AF rhythm becomes regular, you should suspect third degree AV block on top, but AF should always be irregular even if it is slowly conducted. So if I find AF and regular rhythm, it should be third degree AV block on top, but if the AF is slowed down but irregular, I can call this just AF with slow ventricular rate, which of course needs admission and needs monitoring, but it is not a high grade AV block like in AF with complete heart block. So at the end of our lecture, we can summarize what we understood today from this interesting lecture. We understood how to determine the type of AV block, as we understood the 3 degrees of AV block. We learned today how to determine the type of escape rhythm. We learned today first degree AV block, second degree AV block with both its types, Mobitz type 1 and Mobitz type 2, third degree AV block, escape junctional rhythm and escape idioventricular rhythm, and we understood today the difference between these two escape rhythm and when do they operate, and we understood of course AF with slow ventricular rate versus AF with complete AV block. Our take-home message today: atropine has no effect on third degree AV block, whereas it may paradoxically slow down ventricular rate in Mobitz type 2, and we understood why from the diagram. And 2-to-1 AV block can be Mobitz type 1 or type 2, but we usually consider the worst scenario. And once AF rhythm becomes regular, you should suspect superadded complete AV block, even if the heart rate is more than 6 beats per minute, and so this patient would need admission and temporary pacemaker. Thank you very much for your listening.